Welcome to this clinical presentation on polymorphic ventricular tachycardia, PVT, and ventricular fibrillation, VF. These rhythms represent the final common pathway in lethal arrhythmogenesis. Today, we will examine the mechanisms, diagnostic signatures, and the life-saving management protocols required to navigate these electrical storms. The defining signature of polymorphic VT is a KRS configuration that shifts continuously from beat to beat, indicating a constantly changing ventricular activation sequence. This is driven by spiral wave reentry and multiple circulating wavefronts, while the VF, the ventricular fibrillation, shows completely disordered electrical activation with no identifiable QRS complexes. Both rhythms, polymorphic VT and ventricular fibrillation, are often potentiated by damaged Purkinje cells or ventricular hypertrophy. Patients with polymorphic VT presentation typically presents with a few key underlying etiologies. The most common underlying etiology is acute ischemia or infarction. Other major categories include repolarization abnormalities, branches into acquired long QT and congenital long QT, channelopathies, normal heart, Brugada, short QT, early repolarization, CPVT, structural cardiomyopathies like hypertrophic or dilated forms. In the setting of an acute myocardial infarction, the risk of VF is maximum within the first hour. Interestingly, while most of the heart is ischemic, certain Purkinje fibers may survive due to their high glycogen stores, but they become poorly coupled and trigger the PVCs that lead to VF. Post-fibrillation, you must follow ACLS protocols, immediate reperfusion, beta blockers, and electrolyte correction. So we have here the step 1, the normal baseline rhythm. Step 2, PVC causes a compensatory pause. Step 3, the long RR greater than 5,000 milliseconds. Subsequent beat features severely prolonged repolarization. And then, step 4, R-on-T phenomenon. Premature beat interrupts the vulnerable T wave. Here we have the clinical presentation with presyncope, syncope, and cardiac arrest. Acquired long QT is often induced by external triggers. Our drug trigger radar includes certain antiarrhythmics like sotalol, antibiotics like macrolides, and psychotropics like allopurinol. Metabolic triggers are equally critical. We must aggressively monitor and correct potassium, magnesium, and calcium levels to prevent these lethal rhythms. Genetic mutations in ion channels cause the congenital long QT syndromes. LQT1 is triggered by exertion, especially swimming. Long QT2 is often triggered by sudden auditory startles. LQT3 is the most dangerous during sleep. Management focuses on non-selective beta blockers like nadolol or propranolol and strict avoiding Avoidance of QT prolonging drugs. Brugada syndrome is characterized by a COVID-ST elevation in V1 to V3, often unmasked by fever or sodium channel blockers. Conversely, short QT syndrome features a QT less than 360 milliseconds and a high incidence of sudden cardiac death. Both often require an ICD if the patient has a history of syncope or cardiac arrest. Catecholaminergic polymorphic VT CPVT is a rare syndrome where emotional or exercise-induced stress causes bidirection VT. We face an ICD paradox here because the shock from a defibrillation can trigger a massive adrenergic discharge, potentially worsening the arrhythmia. Early repolarization is often a normal variant, but if it is a marker of increased risk in survivors of idiopathic VF. In hypertrophic cardiomyopathy, HCM, we have an extreme wall thickening greater than 3 cm is a major risk factor for sudden death in young patients. The interventions are surgical myectomy or alcohol septal ablation. In genetic dilated cardiomyopathy, DCM, mutations in the lamin AC and SCN5A genes are highly arrhythmogenic. We have the physical fibrosis creates permanent substrates for sustained monomorphic VT or PVT. In both cases, if the ejection fraction at VEF is persistently below 35%, an ICD is indicated. Synthesizing these pathways, we see that ischemia, drugs, channelopathies, and scars all converge into spiral wave reentry. This results in the disordered activation of ventricular fibrillation, causing an immediate loss of cardiac output. If no reversible cause like an AMI is found post-resuscitation, progression to an ICD is mandatory. So the primary cause of out-of-hospital cardiac arrest is ventricular fibrillation. If no reversible cause like AMM is found post-resuscitation, progression to ICD is mandatory. Our management strategy is fourfold. Acute, immediate electrical cardioversion, defibrillation. With the indication, there are some indications like VF and sustained pulseless PVT. Immediate electrical cardioversion. Treat the reversible cause. TDP rescue. First line, IV magnesium sulfate, 1 to 2 grams. Refractory isoproterenol infusion or overdrive pacing to suppress pulse-dependent PVCs. So we have to do the correction, aggressively correct potassium and calcium. Long-term ICDs for those with persistent low LVEF or high-risk genetic markers. So we have non-selective beta blockers, not like Nodolol, Propranolol as primary defensive for congenital LKT1, LKT2, and CPVT, strict avoidance of QT prolonging drugs. The future of electrophysiology lies in precision medicine. By using simultaneous recording from multi-electrode basket catheters, we can correlate electrical data with structural imaging to pinpoint the exact Purkinje networks or epicardial substrates for targeted curative catheter ablation. Target catheter ablation. Thanks all. See you next time.